Hello and welcome to today's Mobile Response and Stabilization Services Learning Community, our virtual series. Today's topic is behavioral health consultation, and I am so happy to be your host today. My name is Liz Manley, and as you might have noticed, but I'll point out, we have moved the National Center from the University of Maryland to the University of Connecticut to the Innovations Institute. I'm very, very excited about the work that we'll be doing at University of Connecticut School of Social Work. And I'm so happy that you can join us for today's session on behavioral health consultation. We're very excited about our panel. As folks who have joined us before know, I generally am accompanied by one of my parent partners from New Jersey and one of my friends, Hazelyn Pilgrim. Hazelyn, do you want to say hello?
Hello, everyone. Welcome. It's good to be with you all today and looking forward to today's session.
And I'm excited to also be joined today by Dr. Christopher Balanci. Hey, Christopher, you want to say hello?
Hi, everyone. Really excited for today's discussion.
Excellent. So as we get started, we always sort of open up this conversation with the parent's perspective, the family's perspective. So I'm just going to hand the floor to Hazel.
Thank you, Liz. It certainly is an exciting topic today, connecting to clinical services. We in New Jersey and Essex County in particular had the good fortune of doing some of this work a few years back with a pilot project that looked at connecting primary care physicians to child psychiatrists. And one of the things that was most impressive about that experience for us was that we found the clinicians were very eager to have connections with peer support partners and to engage them and connect them to the families that they were serving, connect them to their patients. Because many times parents feel totally out of the loop, confused, bewildered, uncertain as to what to do. And they needed that natural support that could be provided by another parent. And so parent linkage became a great deal of what we did, in addition to linking the pediatricians to the child psychiatrists. Another thing that came out of it was the benefit of really working across silos with the care management organizations, mobile response, um, school districts. That was a huge part of it. And even other providers in the community, like some of our faith-based partners and some of the civic associations, boys, girls clubs, etc. So this is a really wonderful evolution for us to witness. And I'm excited to hear about what Christopher has been doing in Massachusetts and what other folks have been experiencing. So thank you.
Thank you, Hazeline. I'm going to pull up some slides. So by way of introduction, I'm Christopher Balanci. I'm a child and adolescent psychiatrist in Massachusetts. I am part of the faculty of the Innovations Institute. And there's a number of us that actually work remotely. That's the brilliance of this Innovations Institute, that we can provide the kind of technical assistance from wherever our base is. I'm an assistant professor at Harvard Medical School and a senior policy advisor at the Baker Center for Children based in Boston. So I'm going to share a little bit about, probably not a big surprise, but where were we? I was just calculating in my head. We're going on 3 years of a pandemic. But even before the pandemic, we had critical shortages in the area of the children's behavioral health workforce. We have a certain demand, and I'm going to talk a little bit about supply and demand. So we have a demand where we've got 1 in 5 children experiencing a diagnosable mental health condition, and only 20 to 25% of children or youth who need mental health services receive them. That was pre-pandemic. That's not the result of what's happened during the pandemic, where I think many of you know things got even worse. In 2017, for instance, more than 13% of 12 to 17-year-olds experienced at least one major depressive episode, and 60% of these received no treatment. So we really have a crisis on our hands. The American Academy of Child and Adolescent Psychiatry has called it a national crisis, along with our American Academy of Pediatric colleagues and the National Children's Health Foundation. We've got young people presenting in emergency rooms and then not having services available to them. And so the opportunity to talk with all of you, who I think are at the front lines of trying to identify young people with needs and then connecting them to services so that we don't have them ending up in the emergency room, is really exciting for me. And I'm really looking forward to this conversation. I'm not going to belabor the statistics. I think many of you know all of these statistics, and they continue to be grim. Among high school students between 2009 and 2019, we've seen increasing and persistent sadness and hopelessness, serious contemplation of suicide rising from 14 to 19%. Again, this is pre-pandemic data. This is from the Youth Risk Behavior Survey. And suicide attempts rising from 6 to 9%. And then there's subgroups within that data that are even showing more alarm, particularly in the BIPOC community, the Black, Indigenous, people of color communities. And then substance abuse, also we're seeing increase concerning use of alcohol in the past 30 days and marijuana use, and then even heroin, cocaine, and hallucinogens. The pandemic didn't help. How's that for understatement? The CDC data that was done in, I believe it was August of the first year of the pandemic, showed suicide as the second leading cause of death for children between the ages of 12 and 17. And as I mentioned, increasing particularly for Black children. The effects of the pandemic appeared to be associated with higher rates of youth suicidal ideation. And this is the CDC data I was mentioning. Behavioral health related emergency room visits increased 31% for 12 to 17-year-olds and 24% for 5 to 11-year-olds from March, which was just when communities were shutting down and schools were closing, to October of 22, compared to a year previous. So it's unusual that we actually have point in time data during the midst of a crisis. So this was very helpful for us to see just how young people were struggling, and by extension, I would say their families, to meet the challenge of the pandemic. 75% of 18 to 24-year-olds reported at least one adverse condition, and 26% of young adults, many of whom are in child rearing age, reported having seriously considered suicide in the previous 30 days. That was shocking to me. That's Massachusetts data, that such a high proportion of young people were reporting seriously considering suicide in the preceding 30 days. And then, how were adults functioning? Well, they were certainly stressed out, as I'm sure all of you have been as well. Almost 41% reported at least one adverse mental health or behavioral health condition, which was 3 to 4 times higher than the preceding year, again, from an adult-focused CDC survey. And 10.7% reported seriously considering suicide in the last 30 days. And we know if adults are struggling, then so are the children. Particularly in a crisis, the youngest children will look to their parents to say, I fell down, did I just, skin my knee, or is it something more serious? And depending on the parent's response, will also determine whether or not the young person starts, melting in a flood of tears, or, is comforted and reassured that they're going to be okay, and kiss the wound or put a little Band-Aid on, and off they go. And then, I think we do need to talk about the opiate epidemic. I'm using Massachusetts data. I think this has been true really across the country, where we saw a significant increase in opiate-related deaths. And what's interesting in the most recent data that I've been seeing is it's not necessarily tied to increased utilization, but increased potency of fentanyl getting into products, and not just opiate type products, but other products are getting laced with fentanyl now too. And we've been averaging over 100,000 deaths a year in the country. So, we're getting hit on all sides. And then, for every 10% increase in overdose death rates, it corresponded to about a 4.5% increase in the foster care entry rate. So this has carry-on effects throughout all of our systems. And so it's another reason why it's important to be thinking holistically about how you're going to structure your child serving systems so that addressing a problem in one area isn't creating a conflict or a problem in another area, and that you're really thinking holistically about your approaches to supporting children and families. And then the crisis in crisis care. So this is where the supply demand. So as the data showed, we had an increase in demand. We had more young people showing up in emergency rooms with suicidal ideation, with substance use conditions, with depression, with cutting, with anxiety. And we had fewer places to refer them to. Residential treatment units had to consolidate because of COVID restrictions and then ultimately staffing restrictions. Not that that's really where we want to be going anyway, you know, and the whole notion behind the MRSS approach is how can we intervene early, connecting these young people to lower levels of care, outpatient services, so that we prevent the need for the high utilization of the emergency departments, which are not really staffed to be able to meet the demand, as we're seeing with boarding rates through the roof. In Massachusetts, we had significant crisis. So we saw 270 psych beds lost due to COVID restrictions, and we had a big increase in the demand. And then we had a workforce crisis. According to a June 2020 survey of state mental health commissioners, 71% of respondents reported pandemic-related workforce shortages. 73% reported community providers reducing staff or services. Many of these are smaller nonprofits that have very small margins. And so as the pandemic hit, some of these were put into a financial crisis. And there's been some really nice attempts to try to keep them whole and keep them functioning. But this was a crisis even before, and certainly was exacerbated during the pandemic years, with 26% reporting community providers actually closing. And this is a slide I took from the American Academy of Child and Adolescent Psychiatry. You know, not that child psychiatrists are be all end all, and that's certainly, you know, I'll talk a little bit about what the role is for a child psychiatrist, but we have a severe shortage, as you can see, in the majority of the country. Red is a severe shortage, a high shortage is yellow. We have no place that has a mostly sufficient supply. And that hasn't really changed as long as I've been a child psychiatrist. So, you know, while we try to figure out strategies to incentivize young medical students to go into child psychiatry, in truth, we're not bending that curve. So we've got maybe 9,000 child psychiatrists nationally. Many of those folks are also seeing adults. Many of them don't take insurance. Many of them don't work with children in the child welfare system or the Medicaid system. So even the 9,000 that we've got, even fewer are available to, and I would argue, some of our children who are in greatest need. So what have we been able to do? What are some exciting models that we might want to replicate? And certainly we can talk more about in the discussion to come. One exciting model that Hazeline had talked about as well is the model of child psychiatric consultation to primary care providers that's currently been replicated in over 38 states and the District of Columbia. So I was one of the original Mass Child Psychiatry Access Program docs. And the way it works in Massachusetts is, I think we have about 98% of our pediatric practices enrolled, and we have academic medical centers spread throughout the state where they act as hubs for those regional pediatric practices. And what it allows the pediatrician to be able to do is give a call to that regional MCPAP site. They can get a call back from a child psychiatrist within 30 minutes for what I would call a curbside consult. So that would be a quick question. You know, I started a child on an ADHD medication. They're having this complication. I'm not familiar with it. What should I do? Or I have a child presenting with anxiety or depression. I'm not comfortable prescribing SSRIs, which are the class of medications we often will first try for those conditions. Can you walk me through the steps? The idea is not that I, as the MCPAP doc, would take over the direct care. that would be a losing proposition given what we talked about in terms of the shortage of child psychiatrists. The idea is that we're providing coaching to the pediatrician to help to manage that young person in the office, in their practice. And medicines, obviously, I'm the first to say, are not what the be-all, end-all, or where we want treatment to begin and end. So we also need to be thinking about how are we connecting these young people to clinical services that will teach skills, because medications don't teach skills, so that these young people learn how to navigate the behavioral health challenges that they are facing. So sometimes it can just be a quick consultation. Sometimes the pediatrician may actually want me to do a face-to-face evaluation, and we can set that up so that I'm actually doing my own diagnostic eval and then providing a report to the pediatrician to say, this is what I think is going on with your patient. These are some interventions that I think you could try in an office-based setting. And then if those aren't successful, then you might want to make a direct referral to a clinician. And the MCPAP program actually has social work clinicians who help to connect the young people with clinicians who are accepting patients. So there's also that placement resource embedded within the MCPAP system. What we're also doing by setting up that model is hopefully we're expanding the pediatrician's toolbox and ability and willingness to treat some of these behavioral health conditions. Pediatric training is 3 years in total duration. Of those 3 years, they spend about a month required in some kind of behavioral health training site, and usually that's in developmental disabilities. So the ability to assess, diagnose, and treat autism disorders. So they really don't have the clinical training to take on these behavioral health conditions. And there's been lots of pushback from the pediatric practitioners themselves about not wanting to take this additional burden on, even though some studies indicate that as many as 50% of pediatric visits, while not perhaps stated as having a behavioral health reason, include a behavioral health component. So it may not be the primary reason they're going, but it's often something that's going on. And also, if we look at the young people that do go on to commit suicide, most of those young people were seen either by a primary care clinician within the preceding months, or even a behavioral health condition in the preceding months. So these are not young people that are just coming out of nowhere. I think it's a failed ability to meet the need early and connecting them to the appropriate services and supports. So other ideas. So when we think about therapeutic supports, I'm a big fan of evidence-based treatments. They are the treatments that have been shown that they work compared to kind of usual care. Now, there's been criticisms of the way those studies have been generated to show their evidence base. They often will not necessarily reflect the entire community. So often there's racial biases in which young people are admitted into those evidence-based trials. Although there's some interesting studies from the Connecticut Health and Development Institute that showed that actually evidence-based practices work effectively or as effectively for BIPOC communities as well as Caucasian communities. But it's at least a place to be thinking about how do we ensure that young people are getting services that we know are going to translate into improvement in their lives and in their future. So one example is MATCH. So it's the modular approach to the therapy for children, and it covers anxiety, depression, trauma, or conduct problems. And that's about 80% or 75 or 80% of what is driving kids into needing a referral for a clinician. It can treat children from as young as 6 to 17, and it's not a new evidence-based treatment. It was developed by John Wise and Bruce Torpeda, And their brilliance was looking at how do we train a workforce in multiple evidence-based practices, right? So if you're running a community mental health clinic and you have a population of young people where there's a lot of trauma, you may decide, I'm going to train my entire child-serving clinical staff in trauma-focused cognitive behavioral therapy. Well, that may cover, and I'm just going to make up numbers, 17% of your population. And yet you've kind of spent what limited training budget you may have to begin with, getting your clinicians offline to get trained in this, getting them supervision so that they become expert in it. And you still got them only available for one condition. So what Bruce and John decided is they're going to look at, well, what's the magic? What's the common elements in these evidence-based approaches? For anxiety and depression, they were components of cognitive behavioral therapy. For trauma, it was trauma-focused cognitive behavioral therapy. And for conduct problems, it was parent behavior training. Those are all separately evidence-based approaches. And what they created then was a training tool. Actually, Bruce now calls it managing and adapting practice. The idea that you don't just train somebody in cognitive behavioral therapy for anxiety, or even worse, for panic disorders or phobias, something that's so singularly focused that it doesn't have enough of a return on investment for it to be practical and to generalize. So they essentially created training toolkits for clinicians. So it starts with a diagnostic assessment, so you know kind of what you're dealing with. And then if anxiety is the primary issue, then you would start working down the CBT for anxiety module within MATCH. It requires a week of training, so that's, again, formidable, and a year follow-on supervision to become certified as competent. So it's not, again, a small intervention or small level of investment, but at least you would be getting a big return on investments that one would be making. Now, one of the challenges of the business world in which we live is once those clinicians are trained in MATCH, they're actually going to be much more eligible for being stolen from that community mental health center or going into private practice, because now they've got a skill that's even in more demand, and they might be able to demand a higher salary working in a different setting. So we still have to think about kind of the business structures. But that would be an example of an approach to try to train staff, clinicians in evidence-based approaches. And then thinking about a tiered response. So if we think about a public health approach, how do we begin to do kind of universal interventions for the tier 1, which can often be done in a school-based setting? And there's a number of really interesting school-based models of almost thinking about it as an inoculation. So teaching ideas like relaxation techniques. Who doesn't need to be reminded or learn some relaxation techniques? It's the beginning of what is embedded in some of those cognitive behavioral therapies, right? So the first component is a psychoeducational component in cognitive behavioral therapy. For the little ones who they don't realize they're anxious, they realize that they've got a tummy ache and they want to go to the nurse. And so we have to educate them that their tummy ache is actually a sign of a worry. And there's actually, in the Coping Cat manual, which is another evidence-based approach for cognitive behavioral interventions for children with anxiety, there's like a little human figure, and they can kind of talk about where they feel their anxiety. Is it sweaty palms? Is it a racing heart? Is it a tummy ache? So that we can begin to help educate them that when they're feeling this way, they might want to use one of these strategies that we've taught them in therapy. And then we can coach them, we can prompt them until they know how to do it autonomously. And that's where some really interesting work is starting to happen in the coaching side. So schools potentially could be a place, but it's asking a lot of an educator, with 20 or plus students in class to be able to figure out, what does that anxiety look like and how can they prompt the student to use a skill that they may have learned in therapy outside of school. That's certainly a nice option, but it's sometimes beyond what some schools can do. So there's starting to be some experiment using behavioral technicians. So these are often bachelor level individuals. So these are not licensed clinicians, but after the assessment is done, they can actually support the young person as a behavioral coach. So once the diagnosis is made and some ideas around what are some of the relaxation, calming strategies, coping skills that are going to be effective to manage their anxiety, their depression, how do you then reinforce them using that skill with a workforce that's actually not licensed? And this is an emerging field. It's in many ways not too dissimilar to peer supports and to family peer specialists who are helping to kind of sometimes more of a navigation function, but sometimes inadvertently what I would call a clinical function, but not capital C clinical. So we think about how we're going to respond to the crisis with the resources that we have rather than the resources we would dream and want to have. So how do we support the primary care practitioners to manage uncomplicated ADHD, anxiety, and depression through some of these child psychiatry access programs? How do we reserve the subspecialists like myself for the young people who have complicated clinical presentations? Maybe the pediatrician did try to treat the anxiety or depression, but it's getting worse. They've kind of worked the treatment algorithm and things are not improving. So then maybe it becomes time to hand that off to a child psychiatrist who has that subspecialization, or for conditions that are more acute, such as those with suicidality or psychotic disorders, or complicated comorbidities like young people with intellectual and developmental disabilities combined with a behavioral health and mental health condition. And then how do we expand the use of peer support models delivered in the home, the school, and the community? I think those are really going to be the holy grail for how we're going to dig our way out of this crisis and see some of the flexibility that was permitted during the pandemic and decide, well, what were the things that actually worked well? One thing that's worked well is telehealth. And a lot of families have been very pleased with telehealth. And some of the evidence-based interventions have also been very effective through a telehealth platform. One way of working with young people with behavioral health disturbances under the age of 7 is parent-child interaction therapy. And we used to artificially create the setting where the parent would go in a room and the therapist was behind a one-way mirror coaching the parent on how to interact with their child. Well, how much easier is it to actually just zoom into their living room? You don't have to artificially create the crisis. You're seeing it real time. And the parents are very motivated to try out some of the strategies that the behaviorist, the therapist is coaching them on. So, you know,
I have a quick question for you.
Yeah.
I know we were waiting for questions in the chat, but I have one that I think might, oh, look at that. Got time.
Timing.
When we talked about the telehealth, right, and telehealth being successful, the feedback from folks on the ground is that for those it's really successful for, but that there's this whole group of young people who sort of got left behind in this telehealth conversation. And so part of, I think, the question that folks might have is, how do you know the difference, right, between, you know, who it's going to work for and who it's not? And what are your thoughts about making sure that there's other connects? Because I think today's conversation is, how do we connect all these silos and all these approaches, right? Because we need them all, not just some of them.
No, I think it's a great point, Liz. It's not a one size fits all at all. For instance, I don't know that some of the interventions for young people with autisms have been terribly effective through telehealth. I do think some of the coaching kinds of approaches, which a lot of the cognitive behavioral therapies are, It's helping a young person first to kind of rethink how the anxiety cascade happens,
Hmm.
um, or for the young adolescent, how the negative messaging that leads to their depression, nobody likes me, I have no friends, I'm never gonna have a boyfriend or girlfriend, I'm never going to be happy again. It starts refuting some of those
Hmm.
kinds of go-to places that are often fertile soil for so many of our adolescents, often given their lived experience. And so we also want to think about the LGBTQ youth population who have experienced some significant increased risk, and there's so much social uh, I don't want to nuance it, but social hatred being thrown
Yeah,
at them.
right,
Um,
exactly. And yeah.
and so how do they still feel good about themselves? And some of the strategies are actually most effective for the parents than the young people. When I was doing more direct service work, I would actually work with the parent. We'd get the Coping Cat manual. I'd coach the parents on how to use the Coping Cat manual with their child.
Hmm.
And we'd go through a couple of chapters at a time. And what was nice about that is the parents are learning those skills alongside the child. And there's been even some studies that you can actually affect outcomes on the young person without the young person being the direct recipient of the intervention. That going through the parents and using the parents as the mediator or caregivers, mediator of the intervention are equally effective. And those are the kinds of interventions that I think are quite effective. It'd be interesting to think about how that could even start being delivered in multifamily group formats, so that we're, again, increasing the impact that each individual clinician could have. I
Hmm.
think multifamily groups are great because parents love to talk to other parents about what's going on with their child.
Right.
In groups, it's often what the other people in the group say more than what the group leader says that people remember and take home with them. It's much easier to hear from people who have had a shared path. And, you know, I'm a gay white guy, from Harvard. So I'm already not necessarily representative of the families that I'm working with. And so I have to think about how do I overcome that to make my recommendations feel legitimate, and that
Sure.
it's something that families can actually engage in and use productively.
Yeah, I think so. I think there's a couple things, right? So to connect the dots, right, which is part of my job here today, is to connect the dots. When we talk about mobile response and stabilization, right, which is really the focus of this particular conversation, all the things that you've talked about are really important within the crisis continuum, but often get separated, right? So we think of, the consultative model as just being over here and working with pediatricians, when the reality is we want to connect the dots to those pediatricians, right? We want the pediatricians who are feeling a little anxious about, working with children or being concerned. What happens when I see a young person that might have more complexity? Well, we want mobile in there because mobile is the beginning part of that crisis continuum, but it's the beginning part of the crisis continuum where the parent might be saying, something's really going on. I don't know what it is, but I could use some assistance. Or the young person themselves is saying something's not right, right? Like, I know I need some assistance. And either those, very rarely do we get everyone on board at the same moment of time, right? But the power in mobile is that we can help families, right, who are beginning to see that something's going on. Or when we're going to talk about this in a minute, the child welfare, right, our child welfare partners who really need some tools in their tool belt. So I want to make sure that we earmark that. But I wanted to just connect the dots that when we talk about these clinical interventions, all of these things, they're really part of the crisis continuum as well as the intervention continuum, right? So they're part of both of those worlds, and it's important to connect the dots. We don't want just in-home to sit on its, over here, or evidence-based practices to sit someplace else. We want to be able to have our mobile response teams be able to get what they need in order to help guide families to when they're ready for these more intensive interventions, for them to be ready for those interventions to happen, because the goal of mobile is to sort of set the stage for that. I also wanted to just connect the dot to the workforce issue, right, which is so huge during COVID, and it just exposed so many of the challenges within the children's behavioral health continuum. And first of all, I'd just say that we lost a lot of good, folks, clinicians who doing telehealth and who were working in the adult world and all kinds of other stuff. But the role of mobile, of bringing a workforce that is a little less traditional, right, in terms of who it is that we're asking to come in to do that work, sort of fits that conversation that we were talking about, who else can do this, right? That child and adolescent psychiatrists are part of this conversation. Licensed social workers, licensed psychologists, right, are all part of these conversations, but there's a broader group of folks that we can talk about, including youth and parent peer support, as well as bachelor's prepared individuals who are trained and certified to be able to do this work. So that expansiveness of the workforce. So thank you for bringing that up. And I want to pick one more comment, and then I'm going to ask you guys both specific questions. The first is that there are some folks who might be listening who thought New Jersey didn't have any problem in the psychiatric, in the child and adolescent psychiatry world, and your chart demonstrated that that's just not true, that we're really all in the same boat, right? That every state is struggling with the same workforce challenges around child and adolescent psychiatrists. So we really are going to have to think and be smarter about where and how we use resources in this conversation. So
I like to think of it as, helping people to work to the maximum of their license.
yes.
So having people who have circumscribed skills, that's their part of this. But, I shouldn't be treating a newly diagnosed child with ADHD.
Right.
That's a waste of my skill set.
That's right. Well, the other part of that, I think that's important, is that systems have to be organized and designed in a way in which we can have the workforce be where we need them to be to maximize that workforce and the workforce capacity, right? So, organizing your workforce to have your bachelor's prepared and certified, trained and certified folks working side by side with peer support partners, doing mobile response and stabilization and meeting young people at their homes with their parents, really sets the stage to say, okay, where do we move our clinicians then? If clinicians don't have to do that piece of the work, and they're going to use an organized assessment tool that's going to help flag for when and how other resources are going to need to be used, then guess what happens? The young person who's starting to learn the skills in school around, some of the mindfulness and the grounding tools, and they learn how to bring those into their homes, won't necessarily escalate into the higher intensities of service that are necessary, right? So it helps us organize in this preventative stance, because what we know is that there are some young people who are absolutely going to need the services and supports that really are organized around complexity and around, even residential or inpatient care. Like, we need all of that, right?
Yes.
The goal is to have it organized in a way that those who need it get it when they need it at the time they need it. So really helpful. Hazelyn, we talked about peer support, and I don't want to leave you out of that part of the conversation since you have such a huge amount of skill set in that area. So if you want to chat about or talk to us about the work that's gotten done around peer support and how incredibly important it is part of that, organizing the workforce to be
Mhm.
able to be effective.
Sure. I certainly resonate with the comments about there being a continuum that needs to include people with various levels of education and skill sets. And I would also like to reiterate what I've said in past sessions that many of our parents come with various levels of expertise,
They do.
including some in the behavioral health arena, the allied health professions. And so to incorporate individuals with these skill sets in the various programs and services that are being offered to families can be incredibly valuable because we not only bring our lived experience as parents and caregivers, but our academic and professional expertise. So that can be
Exactly.
sometimes a benefit, sometimes a little bit of a double-edged sword because we're not quite sure what hat to don.
That's
But
right.
for the most part, I think we stay pretty true to the peer support model. And there's something to be said for parents connecting with other parents, like you said, Chris, the idea of having that shared experience. That in and of itself has tremendous therapeutic value for parents and also helps them to more readily embrace some of the recommendations that come forth from other members of the team who may be coming from a different perspective. So I think peer support will increasingly be important in this work as we look at ways of broadening the workforce and strengthening the workforce in a way that produces better outcomes for kids and families.
I, I think that's very true. And I've heard you talk about, and I'd like you to just reiterate for folks here about the importance of peer support when it comes to mobile and warm lines and that early part, because it
Yes,
plays a role in helping families be able to be part of the solution early, right? Part of
right.
the
So through our information referral, warm lines, support groups, and activities that typically go on in a family-run organization that provides peer support, families are able to connect before they reach the highest level of need. And that can sometimes stabilize the situation tremendously. You talked about the introduction of certain practices like mindfulness and other tools that can be taught by folks that are peers with
Mhm.
lived experience in those settings. We do a number of things along those lines, and we've been supported by our local system of care in that. And parents do report that it has a beneficial effect on them. And one thing we know is that when parents do better, the kids do better. The less
Yes.
anxious the parent is, the less obsessed with focusing on fixing the child the parent is, the more likely there is to be an improvement in communication, improvement in that parent's ability to cope with and effectively parent a child who may be having challenges, and model for the child even or the young person a way of living with life's challenges.
That's absolutely right. Before we continue, for folks who are listening in, if you have a question and you're on a phone, if you want to press number a star three, we can yeah, we'll unmute you and get your question. You'll be able to ask your questions. So we're hoping if you have any questions, we can answer them. That's so again, it's if you could press star three, that'd be really great. Looking forward to hearing from you. Okay, in the meantime, I
I was just
think
going to respond.
yes,
I
absolutely.
love what you're saying, Hazeline, because I think it really is breaking down this notion of um, what the clinician can do and what non-licensed or peers can do. There's no magic to this, and there's no reason that we can't be doing exactly what you're describing, which is teaching some of these approaches, teaching some of these skills, both to the parents and to the young people. But it
Mhm.
doesn't have to be somebody with letters after their name doing that. I think the biggest issue is how do we pay for that? Because insurers really want to see that, although that's changing too. And I can see
Mhm.
where you were about to respond, Liz. But, um, you know, it's really about, I would argue it's really about a wellness approach
Mhm.
rather than a treatment of disease approach. You know, in the United States, we're very disease focused. You know, in many situations, you need a diagnosis to get care. And I think that's deeply problematic because we don't want to wait for the situation to become a diagnosis before we start thinking about how can we support this young person and their family. And that's where MRSS is right on the front line, you know. And I think it creates an opportunity to think more holistically. In Massachusetts, we've just passed a law that every child can get a behavioral health checkup funded by their insurance. And, you know, now how are we going to train the people who are doing those behavioral health checkups and what's that going to look like and all of that's to be worked out. But that's exciting. And they don't have to put a DSM diagnosis for that session. So how can we begin to think more about those approaches so that we're really moving to more wellness coaching and approaches rather than treating disease? Because when you treat disease, then you go down this path of medicalization, hospitalization, medications, people with letters after their name, yada yada, and it professionalizes and disempowers, I think, the very workforce that we want and need to empower in order to be helpful in addressing the crisis we have.
So before I make a comment, again, I just want to remind folks, if you press *3, you can get your questions. We can hear your questions. But I love what you said, and I really want to repeat it, right? That this is really a wellness approach, right? We often talk about within systems of care that we're trying to really move and organize systems in a way that recognizes the early warning signs, right? And helps young people build the skills that they need in order for them to be able to address whatever the challenges are. And what we know in trauma-informed care, right, when we think about it, we know that the healing environment is in their own home, right? That if we create that healing environment within the child's own home, that the success around that young person is really more, we can see it. And I think we've stumbled on some of this work early in the building of, services and supports like mobile response and stabilization, really within the crisis continuum, to say, how do we just keep young people out of emergency departments? But in the work of bringing it to the home, we've really learned that young people can, use these tools in the community tools and the re-engaging in school really quickly. So, Christopher, I'm just giving you an opportunity to say it one more time because I think people will hear you if you say it. So I think it's really important. And maybe more than one more time, but it'd be great if you said it again.
Well, it's what I was alluding to with the behavioral health techs. We just don't have enough psychologists. We don't have enough child psychiatrists. And that's not necessarily what we need.
Right.
We need to be creating a workforce or utilizing the existing workforce where we can meet kids in the home, in the school, in the community, where we are identifying the need early, where we are then thinking about, is this, something that we're just going to do a quick kind of an intervention and follow, like pediatricians, we'll call it kind of cautious monitoring approach. Or the pediatrician just, has some good common sense or has been trained in some of these kinds of approaches to say, well, try these couple of things and see how it goes, or they can connect them with a peer support specialist to say, I think if you work with this person, I think they'll be able to help you address some of the issues that your child is experiencing. That may actually redirect, a big chunk of kids. And then, if that kind of standard universal response isn't effective, well, then what's getting in the way? Do we need to do more of a thoughtful assessment? Do we need to try some different strategies? Do we have the wrong kind of hypothesis about why the behavior is happening? Do they need more support? What would the support look like? The first thing shouldn't be going to the emergency department. I think it's a failure of our systems when young people are showing up in emergency departments, when that's their first entry into the behavioral health system. Like,
I totally agree with you, right?
Why
And I think
wouldn't that have been detected before now?
And I think that this group of folks who are listening in on this learning community really understand the real significance of moving upstream, really and even more importantly, I think, meeting sense of urgency, having a system that says there's urgency for that parent, for that young person, right? For that young adult who is experiencing something that they need assistance with, that the system, right, the professionals might say, sorry, that's not really a crisis, because today I'm dealing with all of these people who are feeling suicidal, right, who are really dangerous and demonstrating, or whatever it is that happens. And this is one of the challenges in crisis systems that don't recognize children, youth, and young adults, right? Transition age young people around their unique needs, right? I would also argue that specialty or customization needs to be, thought about when it comes to veterans and when it comes to senior citizens. That's not my world, but the world of children means that there were adults who were saying something's going on and we don't know what to do. And if you can arm the people, right, if you can help the individuals who see that with real strategies, that can make a huge difference, in particular knowing what we know about the sequencing of when behavioral health services are most successful for young people, because they're generally not ready when the adults think that they should be, right? The adults say, okay, we see you're depressed, you're going to go to outpatient, right? And outpatient is a really great place if you have skilled clinicians, unless the young person's like not ready, and then they go, this is the worst experience I've ever had, I'm not ever doing it again, it's just never going to happen again. And so this idea of mobile being, part of this, the starting point, if you will, for some young people around the touch. So I promised you we'd get back to this child welfare conversation. And I think it's important for us to talk about young people who are removed from their home because of concerns of abuse and neglect. And Christopher, you already talked about, part of the challenge in systems is that we don't often think enough about children who touch on child welfare. And so, and the needs for these particular young people are really high. And I think it's important for us to talk about how mobile plays a role. How does behavioral health consultation play a role? And are there any particular interventions within the home, within that foster home, that might be helpful? So let's first start talking about mobile, right? And Hazelyn, jump in if you hear me miss a step or a beat on this. But when we were doing some work in New Jersey, when I was assistant commissioner in New Jersey, we prioritized the population of young people in who were in foster care, because we saw this real disproportionate number of young people touch in residential care, right? That was really that they would have 6 moves in foster care, and then residential would happen, right? And it was like this, how do you ever get past that? And it was this kind of really unique situation that happened where our child welfare partners and our children's systemic care folks almost at the same time came to the same conclusion that we should try mobile at that front door, right? And that mobile would play a role, and it has played a significant role. And one of the reasons I wanted to talk about it is because not only did it play a significant role in the residential numbers, which we can see, and we could certainly talk about in no time, but also played this role in what you often talk about is in the role of psychotropic medication, and how New Jersey has one of the lowest rates of the use of psychotropic medication for children in foster care. So I wanted to give you an opportunity just to talk about how important that is, because when we talk, we always sort of talk about the same thing. Like, how did that happen, right? Um,
Right, and it wasn't just by putting in more prior authorizations to drive down prescribers prescribing these medications. Um, I haven't seen the most recent data, but last time I spoke with the good folks in New Jersey was somewhere between 11 and 13% of children in the child welfare system were taking a psychotropic medication. That's barely above what the general Medicaid population is. It's a third of what most of the national data suggests. And it's hard data to come by. Sometimes you're comparing apples and oranges, but frequently I see data of around 35% of young people who are in the child welfare system are being prescribed a psychotropic medication, and often being prescribed multiple psychotropic medications concurrently. So I was fascinated by the fact that you guys had such a low utilization. And I do think it's because you're addressing these young people's needs earlier and more effectively, so that it's not getting to the point where people are racing to me to say, please prescribe a medication. This child is in a good placement. They're going to lose this placement because they're tearing up the house and the foster family is at their wit's end. And that's not a good dynamic. It's not a good dynamic for me as the prescriber. It's not a good dynamic for the child who's going to end up on medication that they might not need. It's not a good dynamic for the foster care system and the foster families who are doing their best to meet the needs of these young people. But if we're not providing them the right clinical supports and services, then that's where we end up. So I think the prescribing rates really are almost, the canary in the coal mine of when we've got a problem. Sadly, we've got a problem in almost every state except New Jersey. Like, I mean, I wish I could point to comparable states that had such low utilization rate. And I think it's not because, I worked with you guys on your psychotropic medication program for a number of years, along with 5 other states as a psychotropic medication quality improvement collaborative that the Annie Casey Foundation funded a number of years ago. It's the end result of having a comprehensive children's behavioral health system of care where child welfare isn't separate from behavioral health, isn't separate from developmental disability. I remember when you folded in your intellectual and developmental disability population into your system of care. And how is MRS part of that children's behavioral health system of care? Not something that runs on its own, that's not really speaking to or integrated with the behavioral health system, the educational system, all the other touch points that young people come in contact with. And I think when you have not coordinated that, that's when you get, I'm going to go over here and I'm going to medicate, and I don't really know what else is happening to this child elsewhere. And I don't have any ability to influence what else is happening elsewhere. I was always very frustrated when, somebody just wanted to come and get a prescription, but didn't want to engage with me about what else was going on in this child's life. And I'm like, I can't practice that way. I'm not treating just a symptom. I'm treating a whole child in the context of a whole family, in the context of a whole community. And so I need to understand all the complexities of those relationships if I'm going to be really effective. Medications treat symptoms. They don't cure diseases in behavioral health. In order to continue to get the benefit of them, you have to stay on them. And for some of our medications, like the antipsychotic medications, that can carry a significant long-term risk for these young people. And I'm not saying medications are bad. Medications can often save children's lives. But you also want to have an exit strategy. What's the skill that you're going to teach so that eventually you can taper this child off a medication? So, I'll use a medication for extreme depression or anxiety to the point where the child's too anxious to engage in their anti-anxiety cognitive behavioral therapy, right? I have to turn the volume down a little bit in order for them to feel like, okay, I can try this scary thing that this doc wants me to try, like confronting my fear. or using relaxation approaches. It sounds silly. I don't want to blow bubbles. I don't want to go for a walk. I want to do this other thing, but I'll try it now. Whereas before, they may just be too paralyzed. And you're also helping, if we go back to this is a wellness, this is something that you're then teaching the child they can have mastery and competency over. What a powerful message for anybody who comes through that and says, I can do this. I can face this. That's not going to, and that's actually what a lot of the CBT approaches, they talk about kind of that mastery approach, whether it's depression or whether it's anxiety, even suicidal ideation and cutting. If you think about dialectical behavioral therapy, which is specifically an adaptation of cognitive behavioral therapy for chronic suicidality and cutting, that's teaching skills. I love that, because then I can say, well, we're going to do this for a little bit, but only, and you have to be careful, because if you're too good at it, there has to be some motivation to do this hard work. There has to be some motivation to change. And so if you just numb them out with medication, where's the motivation going to come from to engage in this difficult work?
I think the medication conversation is really complicated, right? Because we wouldn't rule it out. It's like residential. We're not going to rule it out as one of the things that we need in our tool belt. But at the same time, part of the challenge, I think, that systems have, states have, communities have around organizing is behaviors don't tell us really what's going on. Like, what I learned is that the size of the behavior, the throwing of the chairs or whatever, didn't really give me a clue into how to make sure that the young person was moving forward, right? We need something more than the size of the behavior in order to understand it. And what mobile response does is it gives us that beginning part of being able to say, we're going to do an assessment that is child specific, it's young person specific. It takes into consideration all the things that you talked about already, that you need to understand the environment, right? What else is happening? What tools are available for young people? What are missing? Is there a trauma history here that we need to pay attention to? Can we organize the home in a way that recognizes that trauma? Has the parent experienced the trauma, right? Has the grandparent, right? What other, is the family system's been, disrupted because of some significant loss? That, there's so many things that happen that mobile plays that front role of saying, this is more information that we've gathered to be able to say, look, there are tools that we can put into place. And I think those tools are really important, and why folks like Hazelden play such a really important role in making sure that that front end of your system, that beginning part, in that sense of urgency that families experience, is met with a sense of urgency, because they come to rely on the system to be helpful. But Hazelden, I think that you've done a lot of this work, right, of engaging families in the early part of these conversations when they're beginning to see some shifts and changes in their child, even for children in child welfare, right? Because the first pilot in New Jersey, the 46 out of 46 of those young people in foster care stayed in that first bed. Many of them returned to their biological family with supports in place, because there was a calming, and family said, oh, wait, if they could do that, maybe we could do that. And child welfare partners said, maybe we could team on this. Maybe we could look at it different. And that was a pretty powerful, sort of message to the system to say things could look different. But Hazelden, you were pretty involved in all of that. You want to?
Yeah, I was listening intently, and a couple of things that you mentioned I thought were really significant, and that's the move toward really looking at the work that we do from a family systems perspective, understanding the history and the legacy of multi-generational trauma, and how that informs the way the adults in the children's lives respond, and then the children then in turn learn from their environment and the parents and caregivers around them. So I think there's a tremendous opportunity to continue building on the history that we have using wraparound as a way to organize our thinking about how to best support youth and families, and to really also lean in on using a lot of those community resources and natural supports and cultural brokers in the community that understand something about that environment and create pockets of healing, oasis of healing, I think of them as, where it's not necessarily dependent on a formal system, but they do exist. You know, I had the good fortune of speaking with a parent yesterday who has started her own group, one of our parents, who started her own group, and they're moving it around the city. And every other week they get together and just talk, and it has therapeutic value, and it's keeping them in a place of feeling hopeful, which we know is the foundation for any success that we would envision in terms of, you know, clinical intervention, is that the family first must have a vision and have hope that things can get better. So organizing ourselves around the notions of family systems work, not just the focus on the child, the diagnosis, the medication. I think that's really where it's at.
Really, really helpful. And I think so incredibly important. Christopher, you also hit on something else I wanted to touch on, and that is the issue of payment, right? And money and how that systems design sort of works in a way of reimbursement for the services and the interventions. And there's a couple things I wanted to point out. Number one, in 2013, when the first system SAMHSA CMS guidance came out to the children's behavioral health directors. So in 2013, there was guidance to the children's behavioral health directors on what should appear in their Medicaid plans. It included mobile. They called it mobile crisis, but it also included other things like peer support, which was really important. And it was like a moment where you go, that's really good. Like, we're moving in the right direction. But CMS has updated its guidance recently to include, you know, and encourage states to begin to think about reimbursement strategies for services and interventions for young people who don't have a diagnosis, right? Who are in that world in which we know that they're probably going to need some assistance, and so why don't we get it to them early? And I think that that's really thoughtful, and hopefully states are going to begin to think about how to take advantage, or really, you know, consider the idea of really thinking about children who are in that, what we call really that crisis. They're there, right? We know that they're moving there, but they're not there yet.
Yeah, I mean, I really regret that we've organized our whole service system around diagnoses as the point of entry and access and reimbursement, because in truth, you know, the diagnoses we have in childhood, particularly when you get to pubertal age, many of these have, you know, these kids have to meet adult criteria. They make no sense if you look at them, you know, what's actually in the diagnostic manual. You know, PTSD doesn't look the same in an 8-year-old or a 50-year-old, nor would it. You know, why would we expect it to? Anxiety, you know, again, more somatization with the young kids, depression. So it's deeply problematic that you need a diagnosis in order to get a billable service, and that's the way our systems are organized. And you know, I think there have been some experiments, particularly with kind of wraparound models of case rates or per diem rates. I would like to see us continue to do more of that, and document the success of those kinds of approaches. There's been great work happening in Connecticut at Yale and in Ohio, you know, where they've been able to advocate for that kind of case rate approach. Because I think that makes just so much more sense to me than the notion that, you know, kids are just, they're more than their diagnoses, and their diagnoses change, you know, over time, and sometimes from day to day, you know, what the biggest issue is. You know, with Match, the question they ask is not what's your diagnosis, it's what are the top 3 concerns that you
Right.
have. They ask the parent that, they ask the young person that, and that's what they're reporting on the response to the intervention on a weekly basis through a web-based portal. That's really the direction we should be going. You know, it's what matters most to the family. It's what's going to motivate them to continue in the treatment.
Mhm.
It allows us to really, like with an IEP, have measurable goals, you know, and who's doing what, kind of an approach. I'd always wished that we had the power of an IEP, which, you know, people in the educational world may
Yeah.
bemoan IEPs, but you know, that we had something equivalent, you know, an ITP that was actionable, an initial treatment plan, where we could actually hold people accountable to, this is your role, this is what, you know, you're working on, these are the tools that you're trying, these are the interventions, and these are going to be the timeline when you would expect to see some kind of positive outcome. Much more seriously than we do in kind of the general community mental health world.
It is one of the reasons why mobile's so powerful, though, right? Because it sets the stage, number one, by saying we're going to listen to parents, right? We're listening to caregivers. If a young person calls and says, you know, I'm in trouble, I need help, I don't know what to do, we're going to send help. Parent picks up the phone and says, I just don't know what to do. We're going to send help, right? We have it that just go is really one of the, what I think the best practice states would say is one of the organizing principles, right? Is a just go. Parent calls, we just go. And the reason they do that, organize around that, is because there's never been a time where a parent is called and asked for help where you'd say, yeah, they didn't really need it. You know,
Right.
New
Right.
Jersey's
And wouldn't we
experience
rather be
is,
doing that than calling 911
well, that's
or
Yes.
exactly
worse,
right.
calling
It's
child welfare?
right.
Like, you know, why
What
are
does it,
what?
what
Right.
do they do, right? They hang up and they say, well, either I'm incompetent, right? Because I called too early and I don't know what the word crisis means, even though I see it in my family, or they're incompetent and now I can't trust that system to be helpful, right? So when you organize your system around the idea that a parent picks up the phone, that's a big act in itself, right? Big
Mhm.
act. Parents have lots of other things to do, right? We will organize our system around the idea that families are really busy doing other things. So when this becomes the priority, there's a reason for that. I think that makes a huge difference. And so that's why mobile, you know, being that part of the system that transforms the way we begin to think, because guess what happens in the world of mobile? When you get a call from a family and you go to the home and you see what's happening, then you're providing support around the things that are necessary, but may not meet the diagnostic criteria in the way that you might think, but still need those resources. And if you don't provide them, what will happen, right? What will happen is the young person will continue to escalate. And then emergency departments become part of the conversation.
Right.
So I think there's hope, right? I think there's hope that we're beginning to reorganize the way systems design, you know, the children's behavioral health systems are designed, and services and supports for young people with intellectual and developmental disability and with substance use challenges, both when it's for the young person and their own substance use challenge or in the parent having their substance use challenge, that we're reorganizing the way that we think about that work to be able to make it more meaningful for the young people and their families. But that's my thinking about it, and I think we've seen success in that in the best practice states, including New Jersey and Connecticut and Oklahoma for sure. We're seeing it in early rounds, you know, in the work that Nevada has done in even trying to bridge this huge gap in the geographic areas, and some of the real promising states that are doing real investment in mobile, like New Mexico and Utah and you know, there's quite a few states actually right now who are really thinking through the role of mobile. But Hazel, I think this idea, right, this organizing principle that parents don't just pick up the phone, right? I don't know not one parent who had enough time to pick up a phone and call and ask for help when they didn't need it. Am I right about that?
Absolutely, Liz. I mean, I was just sitting here thinking, when a parent calls, it's because things have gotten to be so severe that they've exhausted all of their other ideas about what to do. Just think about it. What parent really says, hey, you know what? My kid had a bad day. Let me call mobile response or call the CSA and see if we can get somebody to come talk to them. Nobody does that. In our
Yeah,
community, in most of the communities, parents are busy doing life. They don't want, as they call it, a circus of people in their home. So it takes a tremendous amount of courage to pick up that phone and call and say, listen, things have gotten to a point where I need additional support and help. And that's one of the things I really am hopeful about is the fact that as we begin to transform systems by thinking a little differently about mental health concerns, behavioral health concerns, and moving more from away from the medical model where it's a disease, an illness, something that you have to be ashamed of or feel stigma about, because in many of our cultures, that's a very real and present barrier to seeking help, toward more of a wellness model and thinking about thriving. I think there's tremendous value in that. And we will see, better outcomes as a result of that shift in thinking. But no, parents don't just call because they need some evening entertainment. No, they're calling because they really need help. And when they need help is right then, not
that's right.
5 weeks from now, not, oh, we have a waiting list. They need it right then. And that's one of the ways that I think having available peer support in some of these other settings can be very helpful and calming to the parent.
That's right.
Just to hear another voice that says, hey, listen, I understand, let me listen to you, let me figure out with you what some of your next steps can be tremendously stabilizing for families.
So as we went through so many different topics today, including, workforce and access and assessment, and I want to make sure for folks who are listening that we really put this conversation into perspective. We want to be thinking about the tools, right, around behavioral health consultation as a tool that's going to really be part of both the preventative system and the intervention system. So we want all of our mobile teams to have access to that, but we also want folks to we want mobile to actually be one of the places that folks use as a referral for it, right? So as we organize some of this work, and we want to think about those evidence-based practices, right? Like match as an example, as being one of the tools in the tool belt for the intensive in-home work that happens, right? For the stabilization services, right? It could be part of that role within that 8 weeks, up to 8 weeks of stabilization that we often talk about being a really core component. Maybe even think about, do some of these services and supports just need to be the place in which our mobile response teams are connecting and in making sure that those links are happening in a way that is meaningful. So in other words, it's going to fit in to multiple parts of the system in a way that's meaningful. And one of the reasons I talk about the intensive in-home is because there are, the trauma-focused CBT is one of those interventions that often gets used with mobile response teams when young people are ready for that trauma-focused CBT. So it could be part of that stabilization service, but it doesn't have to be, right? In other words, we can organize our system in a way that young people can get what they need at the time they need it for the duration that they need it, and that this really important conversation around the clinical interventions that are really wrapped up in every part of the crisis continuum. Am I right about that?
Hallelujah. Yeah, you're definitely right about that. I mean, we have to get out of this dichotomous notion of there's clinical and not clinical, or only clinicians can do clinical. I think there's clear evidence that these are strategies, approaches that are generalizable, that are universally applicable, that we should be doing across the board. That inoculation kind of notion. So even young people who maybe aren't stressed out, but who's not going to experience some kind of challenge in life where they might reflect back and say, I remember when that teacher said we could do this kind of thing. And I say teacher because it's a teachable skill. This
Right.
doesn't have to even be the few mental health clinicians, if you even are lucky to have a mental health clinician in your school. So these should be kind of the universal approaches. And then, when somebody calls MRSS, try to figure out like what's going on, and is it something that can be managed kind of at a low level of intervention, or is it, need some kind of further assessment, or you try some things and you see how the response is to the intervention. And then if things are going great, you back away. And then if not, well, then maybe a further assessment is needed to try to better understand what's not working. And I think that's a pathway that we can use our existing resources. It doesn't necessarily require additional money. It just requires figuring out, as New Jersey did, how do you align the right resources? How do you pool funding? How do you not silo your child serving systems? And how do you just respond and say, tell me what's going on. Of course, we'll come out and help, before it ends up becoming a much bigger issue. And that's my frustration, is when we end up with all these kids in emergency rooms that should have been met and needs met much earlier. There were so many young people, and I worked in residential for 19 years, that I wished I had been able to intervene with years before they ended up there, because there were clear pathways off of this trajectory that they ended on towards residential treatment.
Well, and I'm glad that you talked about residential treatment from your experience. And, I worked in residential for 15 years as well. And when you talk to folks who work in residential and they really have paid attention and read the record and talk to young people and their families and really kind of look at that, they know, as I know, and as you just clearly articulated, that really we could have done this work so much more thoughtfully, right? That it wasn't the young person that was the challenge, it was the system that was the challenge.
Well, and that's where, what's the psychological meaning of having to give a diagnosis to get a service? Hazeline, you talked about the stigma. We shouldn't have to force people to confront a stigmatizing condition in order to get care, to get support, to get help. It's contrary to everything we know about the way people work and the way kids organize themselves. So, we shouldn't set up a system where you have to call 911 or you get referred to child welfare. Why aren't we just kind of doing what MRSS can kind of create and allow for, which is a helping hand, someone to talk to. And then, sure, I mean, I'm not discounting that there's not a clear clinical role, but that shouldn't be the pathway for everybody. We don't have the workforce to meet that pathway, and it's not what we want. I've always talked with kids about what's the meaning of taking a psychotropic medication. We don't want to teach them that the medication controls their behavior. We want them to develop the sense of agency that they're in control of their behavior. Yes. And the medicine may help them to make better decisions, or depending on what the medicine is, to make their symptoms not so problematic, so that they can learn these skills so they eventually don't need to keep taking this medicine, because they're not antibiotics. It's not an infection that's going to go away. And so how are we using these other approaches from a holistic, family-centered, peer support, least restrictive, wellness-oriented kind of a system of care? And I think we've got work to do, because I think for years it's been very medical model, very medical driven. And so we have to figure out how do we turn that on its head. And I think MRSS is really the front line for doing that. So that's why I was so excited and I was talking with you, Liz, to participate in today's conversation, because this is a child psychiatrist. I use meds, I've been trained to do this, but I've also learned the limitations of what those medications can do. And I worry about what's the learned effect. So when I have a crisis, then, the world listens to me. Well, then I'm going to keep having crises because I like the world listening to me. We want to make sure that we're not inadvertently reinforcing the very kinds of behavior that we want to extinguish. And so if we can connect these young people with services and supports early, then I think we'll also do a good job of steering them from those trajectories towards higher levels of care like residential treatment.
You wrapped that up beautifully. You
Mm.
really did. Hazelyn, I'm going to give you a minute. You want to add your,
Yeah, I thank you, Chris. I think that was brilliantly stated. And the more we can educate parents along the lines of the things that you've mentioned about the fact that medication does not have to be forever, and that you want to focus on developing those core skills and a sense of self-agency and ability to regulate and manage one's life without medication and without formal systems, the better off we will all be. And thank you for sharing your perspective.
This has been a really wonderful conversation. I'm so grateful that you both agreed to join me in this really important conversation about how mobile response and stabilization is such a core component of all children's behavioral health systems, and how we really don't want to build a siloed approach to the work. We really want to do the work together and at the table together. So thank you for everyone who joined us today. We'll be back again. We have two more discussions. Next month's discussions is on the technology, and we will talk a little bit about we'll talk a lot about telehealth and the Connect. That's why we want to have this one today. I wish you all well. Thank you so much for joining us, and take care.